Welcome to the InTouch Health webinar series. This is Rachel Gonzalez, and I'll be your host for this webinar. Today, we are featuring Mathew Dietz of SSM Health, Cardinal Glennon Children's Hospital, and he'll be presenting on the growth of their pediatric telehealth platform. Mathew Dietz, MHA, is the Manager of Telehealth Services at SSM Health, Cardinal Glennon Children's Hospital in St. Louis, Missouri. Matt is responsible for developing and implementing new areas of clinical utilization for pediatric-specific telehealth services. Matt received his undergraduate degrees in health management and public health from St. Louis University in 2013, and he received his Master's of Health Administration from St. Louis University in 2015. His graduate research focused on outcomes research of unique care models with complex pediatric care and the relationships between market penetration of the Medicare Advantage program and chronic disease prevalence at a population level. Previously, Matt was an implementation consultant and project manager for Epic Systems Corporation, where he specialized in the ambulatory and web-based suite of applications. He was also a module success owner of PQRS and the transition to MIPS and MACRA. We'll begin our webinar shortly, but first a few notices. You all have been auto-muted. If not, please make sure you mute yourself. At the bottom of your audience console are multiple application widgets you can use. If you have any technical difficulty, please click on the Help widget. It has a question mark icon and covers common technical issues. You can expand the slide area by clicking on the Maximize icon on the top right of the slide area, or by dragging the bottom right corner of the slide area. During the webinar, you will be able to enter questions in the Q&A widget located on your console. Questions will be answered at the conclusion of the presentation, so please feel free to ask your questions at any point throughout the webinar. If a fuller answer is needed or we run out of time, questions will be answered later via email. This webinar will be recorded and a copy will be available on our website. And this webinar should take about 60 minutes, including time for questions and answers. And now, without further ado, here is Mathew Dietz.
Thank you, Rachel, for that kind introduction, and thank you all for being with me today to discuss Cardinal Glennon Children's Hospital's pediatric telehealth platform. To preface this presentation, our discussion today is going to focus on our operational design and our macro level problems we have historically encountered as we built our telehealth platform. We are not going to take an in-depth dive into our implementation steps, our implementation guides, our day-to-day operational details, or those in-the-weeds type moments that we like to normally talk about. Also, this is very much an anecdotal type discussion, so I do apologize to some of you who are looking for a more data-driven or statistical presentation today. That being said, please feel free to reach out to me directly if you are interested in any of those aspects of the discussion, and I'd be glad to discuss those with you furthermore afterward. For formalities, I do not have any financial or non-financial relationships to disclose. To begin, I'd like to talk about SSM Health before we discuss our Cardinal Glennon Pediatric Telehealth platform. For those of you who are unaware of SSM Health, we are a 20-hospital health system spanning 4 states of Wisconsin, Illinois, Missouri, and Oklahoma. Our system headquarters is in St. Louis, Missouri, which is also where Cardinal Glennon resides. Cardinal Glennon is the one pediatric specialty children's hospital in our system. We also have 39 affiliate hospitals, 2 long-term care centers, 16 urgent cares within our 4 states. And we employ a total of 1,500 physicians, 9,500 medical staff, and over 30,000 total employees within the 4 states. To zoom in on St. Louis, in St. Louis we have 8 hospitals, one of which is Cardinal Glennon, there seen in the red square. Cardinal Glennon is situated about 3 miles from the Mississippi River, which separates Missouri and Illinois. Illinois has a 5-county metro east area, which is part of the St. Louis metropolitan area. There are roughly 700,000 people who live in those counties, and so there is a large population base that is at SSM and at Cardinal Glennon. So we do get patients from both Missouri and Illinois. SSM Health St. Louis also has an SSM Health Medical Group, which has 65 locations and over 350 physicians. SSM also has recently partnered with Walgreens, excuse me, and Walgreens now works and partners with SSM Health. SSM now manages and operates 26 express clinics within Walgreens in the St. Louis metropolitan area. To talk more about Cardinal Glennon, we are an academic medical center affiliated with St. Louis University, St. Louis University Hospital, St. Louis University School of Medicine and School of Nursing, and SLU Care Physicians Group. Cardinal Glennon was founded July of 1956. We just celebrated our 71st anniversary. We are 190 licensed pediatric beds, 65 of which are our level 4 neonatal intensive care unit beds. Level 4 NICU is the highest level designation you can receive here in the state of Missouri. We also have a private pediatric transport team. We have 4 ambulance teams, 2 of which are located here in St. Louis, one of which is in Hannibal, Missouri, about 120 miles north of Cardinal Glennon, and the 4th is in Cape Girardeau, Missouri, which is about 115 miles south of Cardinal Glennon. We also have 1 Eurocopter EC-135 flight team, which also sits at Cardinal Glennon's helipad. Lastly, in 2002, SSM Health and SSM Health Cardinal Glennon was awarded the Malcolm Baldrige National Quality Award. And for some of you who are aware of this award, it is an award driven on performance and quality in healthcare in total organizations. And in 2002, SSM Health was the first Malcolm Baldrige National Quality Award winner in the realm of healthcare. The SSM Health mission is through our exceptional healthcare services, we reveal the healing presence of God. And Cardinal Glennon's mission statement is our love for kids just keeps on growing. Now going in to our telehealth platforms, we have 2 segments of telehealth platforms. The first is our live video and our InTouch Health related programs. First, we have our maternal fetal medicine program, which does high-risk level 2 ultrasounds with MFM specialists live at community facilities. If you are interested in understanding more of our MFM program, you can go to the InTouch website, as Donna Spears, our Director of Maternal Fetal Medicine Services, presented on a webinar in our MFM program last March. We also have our Tele-ED and Tele-NICU platforms, which are our emergent care interventional services. In our Tele-ED, our pediatric emergency physicians provide life-saving intervention to other emergency departments in our region in the realm of pediatrics. Tele-NICU, its sister program, does the same, except with our neonatologists providing life-saving intervention in nurseries and smaller NICUs in our region. We also have our newest program using InTouch called Telepediatrics, which is our outpatient subspecialty grouping of telemedicine-based care. On the right side, in the right column, we have our smaller asynchronous and store and forward or home-based type programs. First, we have our image transmission and cloud-based PAC system. We also do dermatology store and forward e-consults. Our division of neurology does EEG remote reads for facilities. And our division of cardiology provides EKG and echo remote reads, both in the realm of pediatrics. We also have a home-based social work platform, which focuses specifically on postpartum mothers suffering from postpartum depression. Lastly, our NICView platform is a live streaming video service for mothers, fathers, and family members to see their NICU babies real time if they are unable to be in person in the NICU while their child is admitted. So the first type of lesson that we've learned when we were growing this program is in the realm of strategy and strategic growth. And these 3 questions every person asks themselves throughout the entire year. Where are you now? What are you trying to accomplish? How do you grow and develop? And over the last few years, you probably have read articles or have seen articles from the advisory board or SG3 of studies and surveys from hospital presidents and leaders saying 60 to 70 or 80% of them see telehealth as a strategy for 2017 or 2018 or beyond. Well, the question that we had is, what does that strategy actually mean? Like, how do you develop a telehealth strategy? And when we were growing our program, we realized that telehealth in itself is not its own strategy, but instead it enables strategy. And Dr. Lori Sprung of the advisory board put it in words that we couldn't make better. In an article she wrote in 2016, she stated, and I quote, "A virtual care program or set of programs should not be positioned as a standalone strategy. Rather, it's a capability that can enable strategy and is often best used as a stepping stone for achieving a larger goal. So it is important to first focus on the strategic goals the organization is trying to meet, and then map out how virtual visits can efficiently enable those goals to be met." Essentially, we at Cardinal Glennon don't sit around in a room and say, how do we build a telehealth platform? Instead, we look at our strategic goals for that year. For example, what if we're trying to work on ED efficiency and optimization, or what if we're trying to grow outpatient volume? Those might be part of our strategic plan. But then how can telemedicine enable those goals to be met? I also want to talk about Match, Pace, and Lead. And before I begin Match, Pace, and Lead, I really want to thank Steve Krott from St. Luke's Health System, as he is the one who really taught us the philosophy behind Match, Pace, and Lead. And Match, Pace, and Lead is something that we partner with, enabling telemedicine to reach other strategic goals. And this is how we work as an academic medical center, as an outreach type facility, where we listen first. We work with our community partners to understand where the gaps in care are. What are they struggling with? Where is the lack of continuity of care? We listen to their needs and we understand their current operations. At that point, we can co-develop programs together in the realm of telemedicine. Sometimes it's not in the realm of telemedicine, to become successful partners in pediatric care. At that point, we start sharing hospital values. We introduce new avenues of growth, and that's called pacing. And then as we progress forward in our relationships, we begin to become conscious enough that we are okay with exploring the unknown. What are some things that we've never thought of before? And that's how telemedicine really grew at Cardinal Glennon, is we were listening to our community partners, and we were able to match them at a very basic level. Also, so in conclusion for that, and how we kind of set ourselves up strategically, we co-develop programs because our partners find value. We listen to them. We share common goals. When we also work with those hospital partners, we treat them as a hospital partnership. We are moving away from a vendor-client relationship. Those things are too drastically different. In the realm of match, pace, and lead, vendor-client relationships sometimes only match the needs, but we want to grow together as well. And that's of some of our telehealth platforms. That's the genesis of some of them, essentially. Also, align your telehealth strategy with your mission, vision, and goals. When you're doing things internally, make sure that the telehealth programs that you are creating match the strategy, which of course is in tune and aligned with your mission and vision. This is also extremely important when it comes to marketing. If you're marketing your telehealth programs, make sure that the message of your mission and vision of your healthcare organization matches the message you're trying to convey with your telehealth program. The second discussion that we would like to talk about today is how we internally organize ourselves and operate within Cardinal Glennon. Telehealth is a mechanism to break down siloed barriers that we all naturally operate in. Telehealth is a way to cross-collaborate. Every single department, non-clinically, has a role in the telehealth platform here at Glennon. Our strategic team, operations, our clinical departments, our physician outreach and services teams, our integrated health technologies, which is our IHT department, our transport team, our access center, marketing and PR, our outreach and educational folks. All of them have normal roles and responsibilities that to them are just part of the day-to-day aspects of their life. Telehealth is not separate. It's not an enigma anymore. We all work on it together in a cross-collaborative fashion. And we all have the same responsibilities. We want to help people understand the capabilities of telemedicine, just like we do with our normal work. Telemedicine also, in a way, if you think about it from a product lifecycle standpoint, we're still in the infancy stages. It's still a grassroots movement, and so it's the word, it's the message of telehealth. We are also extremely surprised when we start bringing out the message of telemedicine. How many nurses and physicians had ideas, but they never shared them because they never thought it was possible? And so we now see it as our role, our responsibility to turn those ideas into action, show them that these types of new technological means are possible. We also champion being able to navigate implementation barriers. This is specifically focused on the legal, regulatory, political, and reimbursement type aspects of implementation that we all deal with. We all find ourselves to be champions in the knowledge bases of those aspects. Again, going back to educating others to be their own operational champions. We want to empower our physicians, our department and service line directors, ourselves, to operationally own the roles and responsibilities of creating a sustainable and successful telehealth platform. And we want everyone to know that we are a trusted knowledge resource. The silo effect. All of us live in it. We have not created telehealth as a separate silo compared to some of these other examples. Cardiology, dermatology, ED, and so on, most of these departments really don't talk to each other. They focus on their own clinical workflows in their own world. We made sure that telehealth did not follow that same path. Instead, we describe telehealth as a care mechanism, a way to elevate the care of every clinical department. And because of that, again, it embeds itself in every single department. It also does not make sense for the Department of Pediatric Telehealth at Cardinal Glennon to own and operate the patient panel subsets that are seen via telemedicine. We treat the patient panels that are seen via telemedicine and the patient panels that are seen in person the same. They are not different. And to us, it only makes sense that the physicians and the directors of those departments manage both, and we empower them to operationally own them. That in turn makes us extremely efficient, and it creates champions at multiple levels upon multiple service lines here in our facility. To summarize again, telehealth at Cardinal Glennon is ingrained in all aspects of care delivery, from the C-suite down to our clinical staff. It also, because we are making it a mechanism of collaboration, we're breaking down those barriers, those siloed barriers, which increases cross-departmental communication. And by continuously educating, continuously spreading the positive message of telehealth, we strive to empower providers and administrators to operationally own things, and we want to reduce the learning curve as much as we can. Cardinal Glennon, because we are an academic medical center, we have the role and responsibility to work with not just our SSM entities, but other non-SSM external hospitals across the entire region of Missouri and Illinois. 80% of all Cardinal Glennon telehealth platforms are with non-SSM entities, which brings up quite a few new conclusions that we've created after we've gained more data. One of which is called the referral paradox, and I'm going to be discussing that here in a minute. In the realm of tele-ED and tele-NICU, these interventional life-saving type programs, these emergent care type programs, the way we implement them with an SSM facility or a non-SSM facility is the same. Our implementation steps are the same. Our goals are the same. We want to increase the relationship with that hospital. We increase the continuity of care. We close the gap of care among transport. We also go through the same training regimen, intensive clinical readiness. And the goal is also the same, transfer reduction. You're reducing the amount of transfers, unnecessary transfers at that. However, from a practical standpoint, if it's an SSM entity, we would consider that leakage, which is a problem that all health systems deal with, especially when you work in multiple regions. But from an external facility, that's not leakage. We're actually reducing referrals, which has a negative impact on your marginal benefit and your bottom line. And that's what I call the referral paradox, is that telehealth programs with external facilities can and will result in a direct decrease in your overall transfers and referral to your facilities, at least in the short term. Tele-NICU, we've proven, among all the entities, and this is all dependent upon various acuity levels at each entity, that we are reducing transfers, those unnecessary transfers, by roughly 30 to 40% in total. Which means from those entities, we are actually seeing a reduction of 30 to 40% of referrals and transfers to our own facility. Now in a fee-for-service realm, people are going to be scratching their heads. However, at Cardinal Glennon, this is okay to us. It is our obligation as a pediatric academic medical center to provide the best possible care for all patients, regardless of location, condition, or payment. It strives to bring in a quality-based framework, which is a challenge. How do we create value-based care regionally, not just at an entity level? This is what I'm describing as the referral paradox. Our fourth discussion point is education and training. Education and training, after our numerous implementations that we have done with MFM, or Tele-ED, or Tele-NICU, or Telepediatrics, we have concluded that the most crucial aspect of all implementations is the clinical readiness and the staff training. We make sure it takes place among all stakeholder groups at that entity, from the physicians and specialists to the nursing and clinical staff to the C-suite and service line directors. We need to make sure that all of those groups are aligned with the mission and the message of what telehealth can do and the value it can provide. If there are any of those groups that are not fully aligned, it is hard to have a sustainable and successful program. We also leverage Cardinal Glennon physicians as teachers. As an academic medical center, all of our physicians also have a role in the School of Medicine or the School of Nursing, which means they all teach, and they've dedicated themselves to be lifelong learners. Because of that, they are the most willing to go and work with other physicians, specifically the pediatric physicians, in educating them about new best practices, new ways to make more efficient protocols, clinical practice guidelines. And we utilize our Cardinal Glennon physicians in our telemedicine training. We also have an EMS and a perinatal education teams. Our EMS education teams work with EMS agencies and emergency departments around the region to educate them on new pediatric protocols and best practices. Our perinatal education teams does the same with nurseries, pediatricians, and OBs across our region. And by having Cardinal Glennon physicians as teachers and these two education teams deployed at all times, educating, we're able to create a very robust educational and training program for our telemedicine programs. Let me show you some pictures. Here's an example of a Tele-ED training session. This is in southern Missouri. We have a pediatric mannequin in an ED bed that we simulated with a blocked trach. Now, normally, our EMS education staff does this type of in-servicing, even without telemedicine. Some of these rural critical access hospitals may only see a blocked trach once every 5 years. They may never see it. But in this example, we want to teach them so they are clinically ready just in case it ever happens. We are now being able to take it a step further, and we're introducing how Tele-ED can add value to these uncommon and interventional type cases. For example, this is Dr. Stephen Laffey on the RP Lite. He is our medical director of Tele-ED. He now acts as a teacher. He's educating them not just on a blocked trach and providing them guidance, but it's also showing the practical aspects of Tele-ED and telemedicine. It's very easy to talk about telemedicine and Tele-ED on paper, but the way to influence is through showing them in a practical manner, and this is how we're doing it here. Here's a photo of us preparing a perinatal neonatal mannequin for a Tele-NICU consult. And here's our most recent training that we have just done with Tele-NICU. Here's the back of the RP Lite. We are simulating a neonatal resuscitation. And that gentleman in the striped polo is actually one of the local pediatricians who is helping lead the neonatal resuscitation. He himself is doing training not just for neonatal resuscitation, but also understanding the practical aspects of TeleNICU. This photo you can see is the RP Lite, and that's Dr. Ayub Ali, our medical director of TeleNICU, who himself, again, is acting as a teacher, not just a physician. And this is also great education for our physicians, those who do this type of training. It also gives them practice. It educates them. They learn things on a day-to-day basis as they progress with these types of simulations. Then you have this guy, Tim Hewlin, our fearless leader from InTouch. Sometimes he even helps with education. Here he is standing in with our new Vici cart as the nurses and clinical staff are practicing with the new Bluetooth stethoscopes. So to summarize education and training, we turned theory into practical understanding. It's taking just what can telemedicine be, what can tele-ED, what can tele-NICU, what can MSM be, and showing it with something tangible. They can see it. And by doing so, you're reducing clinical hesitancy and intimidation. And that is the #1 reason that we have discovered why there sometimes is a lack of utilization. Because pediatricians, OBs, emergency physicians, and nurses all are still intimidated of using telemedicine. But by showing them this continuous training, we break down that learning curve. It's also practicing clinical workflows and new protocols. If there are new best practices that come out, we want to share them. And we are able to embed telemedicine with our telemedicine sites. The 5th story or discussion point is empowering a yes mentality. And the 7 most expensive words in business, as coined by former U.S. Naval Officer Grace Hopper, we have always done it this way. How many of you have said this yourself or know a physician or clinician who has said this? We've always done this way. So how do you empower a yes mentality? Telehealth fits within this realm. It's something new. We've always done it this way. Why do we need to use telehealth? And so we'd like to share with you 4 talking points that we use to turn a no or a we've always done it this way into a yes. Let's do it. This is something that's for the future. The first talking point we'd like to share is that pediatrics is a prime target. Ever since Y2K, the year 2000, we've gone in an exponential technological boom. You think about it, the iPhone, smartphones have only been out for 10 years. If you look back at it retroactively, you're saying, wow, it's only been that long. Well, the adolescents who grew up through that technological boom are now themselves having children, having families. And those children live in a completely wireless realm. Instead of toys, 3-year-olds want tablets. Kindergartners want cell phones. The world of Snapchat and Facebook, FaceTime, and Skype, that's natural. That's normal. That's the society they were born in. They don't know what a VHS is or what a floppy disk is. To them, a physician over a screen providing guidance in an outpatient setting or an ED setting is the same as what they've normally encountered. And so pediatrics, the child themselves is not the learning curve. The child is not the person we need to be training. It's the parent. It's us. Secondly, patients want convenience. The perfect example of this is hospitality. The hospitality industry, hotels, restaurants, airlines, rental car agencies. We can now do everything at the push of a button. Society has dictated convenience. Things get done fast. There is no longer calling for a hotel reservation. We can do things on our phones. And people want the world to be sped up that way. Healthcare naturally lags behind in the technological realm, behind these types of industries. And now it's our turn. Now we're starting to see society dictate, the patients that we care for dictate that technology and convenience is the future of healthcare. Third, is the healthcare learning curve. In the 90s, whenever you had an x-ray, they would print it out and they'd put it in front of a black light, right? And then they'd take your x-rays and they'd put it in a manila folder. And then they'd say, okay, give this to your physician or your orthopedic surgeon. And then when you had your consult with the specialist, they would look at it the same way. Well, then we introduced PACS. And the physicians always said, well, we've always done it this way. Why do we need to change to PACS systems? And now, I don't know a physician that would say we'd eliminate PACS again. They wouldn't know what to do if they had to go backwards. The same analogy with EHRs, moving from paper to EHRs. I don't know a physician that would want to go back to paper. But it was the same thing. We've always done it this way was the message until they actually started using it. Telehealth needs to fit that same bill. It's a disruptive innovator, just like PACS system and the EHRs were. And we need to educate, and we need to show them the added value. Speaking of added value, telephone encounters is a great example, and the fourth talking point. Telemedicine is not new. Ever since the first telephone encounter, when a physician using limited knowledge has prescribed a medication over the telephone, that was the genesis of telemedicine. And with a telephone, every physician's been doing that for numerous years. They're still able to make a decision using a concise amount of data that's incomplete. Only what the patient's telling you. In the new world of modern telemedicine that we like to talk about today, where you're adding a video component, where you're adding photography in store and forward, the physician now has a more complete record and detail of the true clinical nature of the patient. And he or she can now make a more informed decision using video instead of just a telephone. Our sixth talking point is something that you all might be curious about still. What are our daily challenges? Reimbursement is still a daily challenge. The advisory board actually listed the state of Missouri as one of the top 5 states for reimbursement in the US via telemedicine. But that's relative. We are still very limited in our state alone. It's very hard to still develop a tangible ROI if you're working in a fee-for-service type of model. Secondly, legal licensing and credentialing are still our top delays in implementation timeframes. Now, if you're working with internal facilities, you may be able to eliminate some of this if you share the same legal team or the same credentialing organization, medical staff office. But in Cardinal Glennon's instance, since we have facilities in both Missouri and Illinois that we partner with Telehealth, the legal licensing and credentialing paperwork all vary state to state. To help eliminate that, Cardinal Glennon, the Division of Neonatology and Emergency Medicine, now requires all physicians to be licensed in the states of both Missouri and Illinois. We also are champions for the CMS and JCO telemedicine credentialing by proxy standards, and we continuously educate facilities to adopt and approve of those standards to reduce the delays of implementation timeframes for some of our programs. But those are still challenges. Also, stakeholder acceptance. As modern telemedicine is a disruptive innovation, that's what it is. Quick, drastic shifting of culture and clinical protocols can still result in a reduction of physician alignment. It takes time. And being a disruptive innovator, you're trying to speed up that process. So how do we do it effectively? And that's through a very concise implementation plan that covers all aspects and reduces as many potential barriers to implementation as we can find. So those are our daily challenges that we still deal with on a daily basis. And in conclusion, our last slide, on the horizon, We are still expanding our tele-NICU, tele-ED, and MFM services. We have new facilities that we are implementing at the moment for all of these. We are also growing additional pediatric outpatient subspecialties via telemedicine, both at our pilot site, which is SSM Medical Group in Jefferson City Pediatric Clinic, as well as new sites, and bringing on new specialties. We're also developing more direct-to-consumer-based platforms, such as the home-based social work platform that I previously described. An example of that is the St. Louis Fetal Care Institute, which is housed here at Cardinal Glennon. There are patients who come from 300 to 400 miles away for fetal surgery. But they also need to come here for multiple pre-surgical consultations. That's a long drive for a 45-minute to an hour consult. So if we can do those from home, finding those ways to directly connect to the consumer, we are going to do so. So thank you all so much for listening to the presentation today. I greatly appreciate you all giving me the opportunity to speak with you all. We have plenty of time for questions, and I'm definitely here to speak with you all and answer anything that you may be curious about. Thank you.
Great. Thanks so much, Matt. So as Matt said, we will now begin the question and answer portion of the webinar. Feel free to get your questions in through that Q&A widget located on your audience console. So first question is, how do you get physicians and nurses to be willing to take the time to go through all the training and updates?
So when we go through an implementation, and I'll just use tele-NICU as an example, a standard tele-NICU implementation, we have our subsets of what we need to get accomplished, be it the technology, the legal, the contracting, the credentialing, and so on and so forth. But we also have a subset for training. And we start at the very beginning, just introducing demos, especially to those sites that are brand new to an RP Lite, or they've never seen an InTouch cart before. We really start from the very beginning there. And we go through multiple demos, multiple workflows. We spend a lot of time on site with them. Now, from a nursing standpoint, InTouch has made it very easy for the actual nursing workflows using the technology. I mean, it's very basic. Make sure the cart's plugged in, how do you connect, those types of things. There's not a lot of stuff they have to do technologically speaking using the carts. The clinical readiness is really the piece that we focus on with training, and that's understanding the practical knowledge. What do you normally think you'd be, calling for? Let's go through those types of simulations. But then we also have our optimization and our maintenance plans. So once we do go live, we usually do quarterly refresher training with all clinical staff in the nursery or in the EDs. And that's a way to kind of keep them still up to speed, making sure that we're using it properly. And at the same time, it allows us to gain feedback on what we can also improve upon.
Great. The next question is, how are you getting your physicians to say yes and aligning internally?
That goes back to being an academic medical center. We strive to have a culture of learning and be willing to share knowledge internally. And because of that, because all of our physicians are somehow in the realm of academia or research, they're also learners, and they're naturally curious. So actually, internally, aligning them is some of the least difficult aspects, actually.
Okay, and then how do you financially sustain this program?
Financially, we are a pediatric not-for-profit, so we do focus a lot on grants. We also have our Cardinal Glennon Foundation, which is our philanthropic arm, which helps with funding. And then there's a lot of that back-end complex budgeting, those types of things that that we also work on as well. But a lot of it is through grant funding, and it's through our foundation that helps support these types of cutting-edge programs.
All right, and we have another question here. Are you willing to share best practices and protocols, and do you have physician champions who are willing to have those conversations?
We do have our two medical directors. We have a medical director of Tele-ED and our medical director of Tele-NICU, Dr. Stephen Laffey and Dr. Ayub Ali, respectively. They are kind of our physician champions and our leaders for those two platforms. We also publish all of our clinical practice guidelines and our protocols online on our website. So if any of you are interested in that, we actually make all of that readily available. Cardinal Glennon also has our EMS app. So if you are interested in any of our ED clinical practice guidelines, you can go onto your phone and you can download our app from your Play Store or your Apple Store.
Okay, and what are barriers to your growth, not just operationally?
Financially is always a big one. That's a big barrier. And then also, the larger you grow, you have to find new ways to remain just as efficient as you are now. And that is something that we take a lot of pride in, is how efficient we are in our growth, how exponentially we do grow. And so it's just trying to find new ways to work smarter and think smarter.
All right, it looks like that is all of the questions that we've received so far. I'd like to give a big thank you to Matt and SSM Health for today's presentation. If you have any additional questions, feel free to reach out to Matt directly or reach out to us at feedback@intouchhealth.com. And you will receive a recording of this webinar via email later today or tomorrow morning. And you can also access this webinar and other webinars on demand at our website with this link on the slide. And that concludes today's webinar. Thank you all for your time and have a great day.